Science that goes along with this if we're to make it a believable discipline. Dr. Jeff Marks is going to talk about the potential infectious implications of notes.
Good morning. I want to thank Drs. Ratner and Ponsky as well, and SAGES program committee for inviting me to participate in this panel today. As Jeff Ponsky alluded to, the science behind a lot of this isn't very deep. And when we look at this, if you could bring up my slides, please, is not very deep in terms of where we're going with lots of issues. Dr. Rothstein showed you a lot of things that are preliminary work, because access and closure were easy. We knew that we had to open things, we knew we had to close them, but all the physiologic effects of notes and such are still underway in terms of investigatory stuff. This is my list of disclosures. None of them have influence on today's talk. In terms of an overview of where we're going with today's talk, I've been asked to discuss infectious issues and possibly the use of some type of sterile conduit to prevent any contamination during a notes procedure. So we're going to study some of the infectious investigatory studies to date, some past research that maybe have some analogous information for us when it comes to notes. Because if we haven't investigated notes, what other type of procedures have translational ability to us? Maybe some of the concepts of actually what a conduit might do in terms of preventing contamination, and maybe at the end formulate some recommendations on these issues of notes for infection. So Dr. Rothstein discussed the first two issues on our white paper, access and closure. Infection is listed third, and I know this list was made up not so much with a priority, but basically with an importance at every level, and I think that the prevention of infection obviously is important. We are putting a hole in the GI tract, or the gynecologic or urologic tract, and replacing an incision on the abdominal wall. So this is an important thing to understand. So last night when I Googled notes, natural orifice surgery, I came up with 30,400 citations. None of them were any legal firms just yet, which was good. But when I went to PubMed to look for some matching types of issues, only 45 citations came up. So despite the fact that we're very interested in notes and there's lots of fervor about this, there's not a whole lot in the published literature such yet. And in fact, of those 45 papers, 15 described some concern for infection. Only 2 of them were actually investigatory studies based on infection. And then there were also 2 abstracts that you'll see in today's plenary session, or tomorrow's, plenary session on notes. There are multiple other studies, though, that maybe we can look at and learn in terms of a historical control when it comes to infection with notes. So we're going to talk about that. So one of the first studies that we did in our lab was looking at the bacterial burden of notes. And this was a survival study in a porcine model, 20 animals. And basically, this was done with PEG closure. Early on, in our experience, we felt that we didn't have a good closure device just yet. We did know that PEG is a tool that's been around for almost 3 decades, has been used to obviously control gastrotomy or colotomy in terms of a tube fistula. And so that's our project for this one. And we went ahead also, because of our interest in diaphragm pacing, and left a foreign body in the abdominal cavity. Intraoperative cultures were obtained in the gastric fluid prior to the notes procedure, as well as at time of sacrifice from the peritoneal cavity at the beginning and end of the notes. Animals were survived for 14 days, and necropsy was performed. One of the things to understand is we went through lots of different series of different lavages, large volume lavage, small volume lavage, antibiotic lavage, and we could not adjust any of the microbiology in the porcine stomach with this study. But what we did find is there were lots of species that were identified, and this was, again, despite any type of antibiotic washes or lavage, that there is a full library list here of different types of organisms, some very common to humans, but some that are also a little bit different. In terms of bacterial growth, what we found is that there was almost 10 to the 4th CFUs in the mouth. There was a similar amount in the stomach. These obviously were not on acid suppression, so there was no role for PPIs. We'll talk about that in a little bit. And again, almost half the animals grew out a similar amount of almost 10 to the 3rd CFUs of bacteria from the peritoneal fluid once the scope was introduced. So this is before necropsy. This is at the time of the procedure initially. And then at the end of the study, after the survival study, we found a similar amount, grew from the peritoneal cavity, and half of the foreign bodies, the wires that were placed initially percutaneously, also grew out bacteria. Despite the large amount of bacteria that was introduced in the porcine model, all the animals survived. They did have microabscesses adjacent to the stomach. As I said, 50% of the foreign bodies were culture positive, but as I said, all the animals thrived. So again, it questions the physiologic effect of this bacterial contamination in the procedure of NOTES. In another study that you're going to see tomorrow, and I don't want to steal their thunder, and this is from the San Diego group, they did another survival study using a rat model looking at the issues of PPIs. I think one of the things that we'll have to remember is what kind of patient preparation are we going to do for our patients when it comes to any type of transgastric procedure. They basically took a small volume, 2 cc's of intragastric contents, and then contaminated the peritoneal cavity in the series of rats. And they looked at the gastric pH and the peritoneal pH in the survival study at the procedure of the laparotomy as well as 2 weeks later. And what they found is that the infectious complications were much higher in those animals on PPIs, from about 20% up to 60%. And again, you'll see their series tomorrow, and I recommend that you attend that session as well. But the thing that we need to understand is that rats and animals are not primates. They are not humans, okay? One of the issues is that obviously the physiologic effects are quite different. The bacterial overload that we have versus animals is quite different. They have never been exposed to antibiotics or hospital situations. So again, the flora that they contain is different. And one final thing is that the animals that we utilize in the lab are infants. Okay, a 40-kilogram pig is about comparable to a 6-week-old infant, or human infant. And so there are definite issues in comparing animals to humans, and we need to understand we have to take this with a little bit of grain of salt. In terms of human trials, the Ohio State group has done some good work looking at some infectious issues when it comes to NOTES. In terms of this study here, which initially was published as an abstract with 10 patients, there are now up to 50 patients. This was recently published in Surgical Endoscopy. And they looked at intraoperative cultures at the time of Roux-en-y bypass. This was done with a nasogastric tube. There was no intraoperative endoscopy or transgastric endoscopy. So again, it's not actually NOTES, but it is looking at peritoneal cultures as well as gastric cultures in terms of contamination. These patients were all followed up, and what they found basically that the initial gastric cultures in these patients grew out about 62% of the time. There was growth of bacteria. The peritoneal cavity prior to any gastrotomy was much less, about 12%, and post-NOTES procedure, or post-Roux-en-y bypass was almost 50% of the time. Interestingly, when we separated this out based on PPI use in this group of patients, that the load of bacteria that was evident, not only in the stomach but in the peritoneal cavity, was significantly different with the role of proton pump inhibitors. And I think this is very important to understand that acid suppression will allow overgrowth of bacteria, and this is obviously well known to us. And I think it is one of the things that when we come to patient preparation that we're going to obviously have to pay attention to. Another series that was done, okay, in terms of bariatric procedure, not so much for NOTES procedure, was the looking at the bacterial contamination in the peritoneal cavity at the time of Roux-en-y bypass. Again, there was no transgastric endoscopy. Basically, peritoneal fluid was aspirated at the completion of a Roux-en-y bypass adjacent to the enteroenterostomy, and 22% of the patients had positive cultures from the peritoneal cavity. Despite that, none of these patients had any untoward events. They all survived without any difficulties and no had infectious complications. So again, it kind of shows us that the peritoneal cavity does tolerate a reasonable amount of bacterial contamination. Well, what about decontamination of the stomach? Is it necessary? In another series that's going to be presented by the Ohio State group, this is an abstract on tomorrow's plenary session. They again looked at transgastric access under laparoscopic guidance in a small series of patients, and they found that without any bacterial washing of the stomach, these patients had no untoward events. Cultures were very minimal in terms of the bacterial growth, and again, you'll see this in full tomorrow. Well, what about other access sites? And Dr. Rothstein talked about different access sites, and I'm predominating this going to be on the transgastric approach for this talk today. But I think the other thing we need to understand is the flora, obviously, of the gynecologic as well as GU systems. Obviously, the microflora of the female anatomy is probably not something that most general surgeons or GI surgeons are terribly aware with, but it is quite diverse. And in other events, whether it be after antibiotic use or obviously as a change in this bacterial flora, and this is something I think that we'll have to ask our patients prior to any transvaginal approaches. What about ways of identifying this in the literature? Well, as I told you in the beginning, there is not a lot of literature based on NOTES, but if we look at what is probably the very first true NOTES procedure or transvisceral procedure, it was probably a PEG. PEG is basically taking a tube across the gastric lumen, out into the peritoneal cavity, and then back out the abdominal wall. And there has been a lot of literature looking at infectious consequences with PEG tube. So let's see if we can translate some of that issues to NOTES itself. So in this prospective double-blind study, basically it was able to show that wound infections obviously are much, much higher without antibiotic prophylaxis. And most of us that do PEG procedures, we know we have to give a dose of antibiotics, otherwise our wound infection rate is going to be much, much higher. Well, what else do we know in terms of large series? So this meta-analysis looked at 7 series. 2 of them did not have a positive result in terms of antibiotics, but after pooling, the reduction rate for infection was 73%, and the absolute risk was reduced by 17%. So it is obviously a standard of care. We give a dose of antibiotics. So obviously we must take this into account when looking at NOTES infectious issues. Well, it's going to require some type of prophylactic antibiotic. Well, why do people get infections when it comes to PEG tubes? What is it about poking a hole through the stomach and bringing it out the intra-abdominal wall? What is the risk for infection? In this prospective trial of patients with head and neck cancer, so obviously these are immunosuppressed patients, they looked at nasal and oropharyngeal cultures at the time of PEG placement to try to correlate any infections, obviously in the upper GI tract, with infections that may occur during the time of PEG. This patient population received prophylactic antibiotics, and they also relieved post-procedure antibiotics until the time of discharge. Organisms, again, similar to what we saw in the animal model, a multitude of not only aerobic and anaerobic, but yeast as well. And one of the things that we find in the humans that we don't see in the animals is a very, very high predominance of meth-resistant Staph aureus. So when we looked at nasal swabs and oropharyngeal swabs in this patient population, nasal swabs in and of itself did not affect the risk for infection, but oral swabs did. And in fact, it was significantly different in terms of having a positive oral swab and having a positive peritubal infection. So again, maybe this is one of the things that we'll have to do in our NOTES patients prior to any surgery. Hopefully it'll be an elective procedure, and we find oral and nasal swabbing. Well, when we looked at this, in addition, not only was it much higher if you had a positive oral contaminant, but also it coordinated in terms of there was a concordance with the actual infection that was cultured at the stomal site. So it is probably the oral contaminant that is leading to the peritubal infection. So this is one thing that we have to remember when it comes to the concept of conduits. Do we need to go as a transoral or a full transforegut or transgastric conduit? We'll talk about this in a little bit. One of the downsides of this study, it was a very small series. There was no mention of PPI use, and this was an immunosuppressed population. This was head and neck cancer, not elective surgery. Well, the nasopharyngeal cultures in that study weren't very important, but what about this study? In this nasopharyngeal decontamination study of MRSA, what they were able to find is that they took a separate cohort of patients that were MRSA positive in the nose and those that were negative, all right? And so the ones that were negative were one arm. Ones that were positive were attempted to be eradicated. They were given Bactroban, okay, as well as Bactrim itself orally, and the patient population then was recultured to identify those that had eradicated the MRSA versus those that still had it. And a standard pull peg procedure was then performed. And what they found is those patients that started out with MRSA negative nasal swabs, none of them ended up with any peritubal infections. Of those that had still positive nasal swabs, despite attempt with antibiotic eradication, had a 100% rate of peritubal infections that correlated with the nasal swabs, and those that had it eradicated obviously were significantly reduced. So again, oral swabs might be necessary for cultures and maybe nasal swabs as well for looking for MRSA. Well, what about other types of techniques? The pull peg technique is something that is predominantly utilized. Introducer technique basically takes the tube, does not drag it through the oral pharynx, and it accesses the gastric lumen through the anterior abdominal wall. So in this prospective double-blind study of looking at introducer technique, and I'll show you some schematics in a second, they were able to show that it was no different than placebo in terms of the antibiotic use risk. So introducer technique does not drag the tube through the mouth, so maybe it is the oral pharynx that is our concern when it comes to this contamination. When we look at basic pull peg technique, a guide wire is advanced transabdominally under endoscopic guidance. A tube is attached to this, and the tube is then brought through the mouth, down the esophagus, and out the gastric lumen. In the introducer technique, an endoscope is still advanced, so there is still a transoral contamination, but the tube itself is then brought transcutaneously into the gastric lumen. So in and of itself, there is no dragging of the tube through the oral pharynx. Well, how else might we protect the tube from the oral pharynx? Well, what about an overtube? Overtubes are commonly used at the time of endoscopy to help maybe with foreign bodies or variceal banding when we have to replace the endoscope across the oral pharynx routinely. And this prospective trial comparing Overtube versus no Overtube in the terms of PEG procedure was performed. Again, IV antibiotics were given as well as in the postoperative period. And what they found is that those patients that had an Overtube placed had a significant reduction in peritubal infections from 33 down to 5%. None of these required surgical intervention. And interestingly, of the 28, in this group of patients, again, the limitation was no proton pump inhibitor use was identified, and there was no correlation with the oropharyngeal culture. So despite the fact that they were claiming that the introducer technique decreased the peritubal infection rate, we don't really know confirmatory-wise that it was not because of oral contamination. Another way of preventing the tube from going through the oropharynx is by silicone covering. The Nutrex PEG system, which is not available in this country, is a silicone covering like a nasogastric tube over a PEG. The nasogastric tube is placed into the gastric lumen with a pull technique, and the PEG tube is pulled out of it. So it prevents the PEG tube from crossing the oropharynx. And in this non-randomized retrospective trial, basically they took cultures on day 0 and then stomal cultures at day 7. There was no consistent antibiotic regimen, as this was a retrospective trial. A large amount of MRSA, again, as stated in the previous trial. This is something I think that we need to pay close attention to. But basically, the non-covered PEG had a significant rate of peritubal infections of 33%, and the covered PEG, again, down to 2. So a very consistent pattern, similar to the antibiotic to no antibiotic group, going from about 30 to 5, the covered PEG to non-covered PEG, overtube to non-overtube. Again, very consistent rate reduction of about 6-fold. One of the things to understand in this case series, of those patients that had the covered tube, even a dose of antibiotics was not necessary. 28 of the patients were performed with this covered PEG tube, and none of them got an infection. Well, what type of access systems are available? You saw several slides in Dr. Rothstein's study of introducer type of conduits from Ethicon as well as others. This is a gastric peritoneal access system from the Apollo Endosurgery group. It is still under development, but basically is an overtube that would go transgastric and have balloons on either side of the gastric wall to help prevent any contamination. This is not under any series just yet. It is something that is still in development. So in conclusion, from all these studies, again, it is not a lot of science, but I think that we can take some of this to make some recommendations. I think we need to pay attention to the medical issues, the role of PPIs as well as antibiotics. I think PPIs need to be held to allow for full return of appropriate acid content in the stomach. I think based on PEG literature, prophylactic antibiotics obviously are going to be necessary when it comes to performing any type of transvisceral procedure. In terms of the role of a transoral conduit, I think this is something that I think is going to be a little bit more difficult to obviously come to a conclusion just yet, but there definitely is some orogastric peritoneal contamination that occurs based on PEG literature. Naso and oropharyngeal contamination or decontamination may be a necessary role, and the concept of MRSA swabs of the nose and oropharynx may be our standard of care when it comes to patients before doing any types of notes procedure. The transgastric conduit, again, I don't think there's enough data just yet to prove that we are going to have to perform a conduit from the mouth all the way into the peritoneal cavity. There is no available instrumentation just yet, but I think this is something to put on industry's hands, come up with some type of tool that makes it easy to do this, and it will allow easy access for us. In terms of the actual infectious sequelae, I think one of the things to understand is the peritoneal cavity is a wonderful organ. It takes contamination quite well, and patients do quite well, and so the overall clinical significance of having intraperitoneal bacterial contamination, I think, isn't as great as what the contamination rate is going to be if someone has a leak. So closure a week later and leaking is going to, I think, much worse than the initial sequelae of contamination from bacteria at the time of notes. Thank you very much for your attention.